Cedars-Sinai Medical Center. Dr. Ouyang has an impressive academic background, having earned a degree in statistics from Rice University, followed by an MD degree from the UCSF School of Medicine. He completed his internal medicine residency and cardiology fellowship at Stanford University, where he also completed a postdoc in computer science and biomedical data science. As a physician scientist at Cedars-Sinai, he has expertise in cardiac imaging and leads a pioneering research group that focuses on the integration of deep learning, computer vision, and advanced statistical methods to analyze large molecular data sets. His work also spans the development, understanding, and deployment of AI technologies in cardiovascular medicine, particularly in echocardiography and advanced imaging. His research has been widely published in prestigious journals, including Nature, Nature Medicine, New England Journal of Medicine AI, Circulation, JAMA Cardiology, and the European Heart Journal. Please join me in welcoming Dr. Ouyang, who will be delivering our ground rounds talk today. Thank you for coming.
Thank you for the very kind and very generous introduction. I'm really excited to be here, and I feel like there's not enough kind of communication. Just we are only like 15 minutes away, and I really appreciate Dr. to talk a little bit about my work as well as some of where I see potentially AI and cardiology is going. I was saying before this fun fact, like my son was actually born here 2 years ago, so it's a beautiful hospital, and definitely want to do more kind of cross-city collaboration. So, at a high level, I'll talk about the background, why AI is really exciting now. I'll talk about the clinical need of kind of why that intersects with what we want as clinicians and what we need as patients, and ultimately 2 vignettes in terms of AI imaging, in particular echocardiography, with a focus on precision measurement and a focus on precision detection of disease. I'd like to start even outside of cardiology, and I start kind of pretty much most of my talks with this picture that was published 10 years ago. But this is actually not someone with disease, but simply a truck driver. Over the course of like 20 or 30 years, you can see that he's had asymmetric sun exposure. And I think that this, to me, perfectly encapsulates the idea that a picture is worth 1,000 words, right? Even the most verbose of us, when we're writing EHR notes or anything, probably wouldn't document something like the fact that his face is different from the left and right. But it has that information that describes the inheritance, the environment, this phenotype that here we interrogate with visual imaging, but at the end of the day is actually something that is related to clinical outcomes, what we as clinicians and patients care about, right? His skin cancer risk might be slightly different from the left and the right-hand side, but it also speaks to this is a lot of information that is unstructured, unrecognized, and also underutilized, right? Even when you do machine learning on EHR or kind of, I would say, kind of more structured elements like AAV, things like that, you have a lot of features that are important. As a cardiac imager, we know many different measurements and many different ways to assess risk, right? Things like ejection fraction, kind of is bread and butter, ordinary calcium, the amount of scar on an MRI. Those are all things that we as humans have recognized that imaging links the feature or region of interest to a clinical outcome that is actually important to how we take care of patients. But at this end of the day, there's so much more, right? Even kind of, I would say, scar and something that's really been more recognized in the last 20 years. Like 20 years ago, no one used that. That was not a prognostic sign or a feature, even though we now know it actually strongly portends risk in HCM or kind of type of disease and many other things. We're really at the tip of the iceberg, and that's where I would say it's really interesting and impactful, where potentially machine learning can actually help us uncover or filter up a lot more features that might be useful for us as physicians in the future. So with that in mind, the one thing that I think that people often miss if one doesn't do clinical work is that there is the Achilles heel of medicine, and I would say the Achilles heel of echo, is that there's tremendous clinical variability, right? That's something that is both something we think about in determining or developing machine learning models. Like, what is a good label? If this is a label that's very heterogeneous, maybe the model can't learn too much from it, but also what is the clinical need? And the clinical need is that frankly speaking, if you see two different doctors, sometimes you might get four different opinions. And this scales at the level of treatment, so like what therapeutic intervention you want to do, but also at the level of diagnosis, right? Many people will look at the raw data differently, and that has tremendous downstream impacts on what we do with the patient and what diagnosis like that. The example I like to give, and this is kind of, I would say, I've been at two institutions, Stanford and Cedars, but this is not meant to make either of them look good, but I think it's reflective of clinical medicine, is the left-hand side are two histograms of the ejection fractions that have been reported in the last 30 years. And I've colored it where that if the number ends in 0 and 5, it actually is in red, and if it's in any other number, it's in blue. And this is the highlight that in a non-physiologic way, we are much more likely to present or kind of determine ejection fraction of 30, 35, 45, 50, even when we're using method of discs, even when we're quote unquote doing it quantitatively. So I remember at UCSF and Bolger often like to say, we can't actually super precisely assess ejection fraction, and I'd rather describe buckets, but to the degree that we are even measuring things, we're putting our finger on the scale. And the reason I describe it's a finger on the scale, particularly for EF, is that if you then look at the fundamental underlying numbers, so EF is obviously calculated from end systolic volume and diastolic volume, you don't see this relationship, right? There's not a strong preference for certain numbers or certain ranges, but this only happens in EF. And I would hypothesize that's because there's human intuition and quote unquote human cheating in how we assess the EF, right? If it looks a little bit wonky, but it's really close to 50 and the sonographer measured 50, I think it's rough. I'm going to bring that EF down. And when I do that, I probably bring it to 45 or something. I don't say 46.7 or whatever kind of the calculator does. At the end of the day, this is what I describe as the Achilles heel of imaging in general and medicine in general. There is a lot of variability. So there's not enough studies, but when people look at what blinded variability in EF is, which again, I harp on EF because it's one of our most basic measures, right? Anything when it comes to strain or any other measure is more complicated. And if anything, the evidence is maybe worse. But blinded human variability is on the order of 8 to 13%. If two people saw the same echoes in a different time point, they might have different variation or different measurements. That actually is enough to go from half ref to half path or kind of severe to moderate. That's very reasonable. So oftentimes when we assess clinical change, we actually have to look at the prior image. We can't just say, oh, it went from like 35 to 45. Secondarily, I would say that humans are fatigable, right? So the ASC recommends that we measure 5 consecutive beats, particularly in patients with AFib, because they know that the measurement is imprecise. But I would definitely say of all the places I've given talks, as well as the places I've worked, I am not sure I've met a lab that does this consistently clinically. Right? I don't know, and you guys don't have to tell me if you do or not.
Definitely do.
But in general, even sometimes
too early.
even sometimes to get the snockers to do one is kind of like pulling teeth, right? A lot of times we visually estimate, a lot of times we don't do it we don't do it quantitatively. But what I would like to say is that has tremendous downstream implications, right? At the end of the day, it is in the inclusion criteria for all our heart failure trials. Maybe if we assess EF a little bit differently, maybe TopCat would be different. Maybe if we assess a lot of things differently, even if you kind of believe kind of Castle AF, it had an 8% change in EF. That's within human variability. So one hopes that kind of every study did in a blinded fashion, but one can never be sure. And frankly speaking, most trials don't release their data or visual data, so you can't actually adjudicate in a more kind of grounded or kind of maybe a unbiased way. So, and I am definitely an echocardiographer at heart. So I like to say that even though I mentioned this is for EF, it is a basic thing. This is actually intrinsically true across all of medical imaging. And one example I like to give is that actually there was a paper published now 3 years ago in Lancet Visual Health, where they actually got people or kind of 20 patients with HCM, and then did something even simpler, measure wall thickness, and had kind of, I would say, approximately like 15 cardiologists measure it and do 3D studies. That variability is just as much as the intrinsic reported variability on echo in how you measure wall thickness, right? And I think that if you look at the images they show, people measure it in many different places, in many different ways. And in many ways, that heterogeneity is where there's imprecision. I like to say that right now it's no longer like the signal to noise of the image, right? It's no longer how pretty the image is. And I'm definitely biased towards Echo because Echo doesn't have the pretty images the MRI does, but it's really the human aspect of interpretation that is the Achilles heel, or is the area that we are seeing as much, if not most, of the variants. So at the end of the day, and I think that these will be the two vignettes I talk about, which is kind of, can AI or ML provide for precision phenotyping? And this is, broadly speaking, can it do tasks that we can do, but potentially faster or more precisely, or tasks that are laborious that we don't want to do? And can it also do tasks that humans cannot do, and maybe provide additional insight either into the physiology or the disease so that we can actually intervene earlier? So about kind of now 4 years ago, I was doing my postdoc at Stanford, and we wrote one of the first papers using vision-based models for Echo. You guys know, since this is a cardiology audience, this is a 4-chamber view. This was a model that actually, at that time, was mostly image-based models, so models that can distinguish between cat versus dog, but we clearly know that EF is a very temporal kind of feature, right, measurement. It needs to know the relationship between systole and diastole and the motion to actually calculate that measurement. But this model was able to both assess the ejection fraction and as well as segment in blue the left ventricle. And what I'd like to say is that kind of you can often tell when a model is doing well when the segmentation from frame to frame does not flicker, right? Kind of that's actually very persistent and consistent across the different frames. What measures to show that it actually has a pretty good representation of where the ventricle is and what the EF should be. Even in the 90s, there's been a bunch of algorithms that have been published, right? Kind of, I'm sure many sites, whether it's like GE or Philips or Tomtech, there have been automated EF algorithms in kind of 20 or 30 years ago. The Achilles heel is really, or how do you distinguish between a good algorithm and a bad algorithm, is what happens when there's low quality images, right? Kind of, I'm sure you guys have seen that, like if you do like the automated thing on your computer, that suddenly the tracing goes into the endocardium or something that like clearly does not make sense. And really that it really mostly works when it's a really high quality echo. And functionally that's not most of our patients, right? We have obese patients, we have patients with lung disease, we have a variety of other reasons why we just don't have really good images. And kind of on the right-hand side is what I like to show is that here are two images that actually the cardiologist did assess. So the humans, well, obviously these images are imperfect, but are within the range of what people think they can assess for ejection fraction. And the model similarly can actually still create a relatively good assessment of where the left ventricle is and ultimately what the ejection fraction is. In this setting, simply because it's software, it can actually do some of the things that we should be doing, but we generally don't. One example I like to give is that actually measure multiple beats. So you can see in atrial fibrillation in particular, or anytime there's a PVC, the beat to beat variation is actually tremendously high. With that, much more of a longer RR, shorter of an RR, their EF would actually vary, but the more beats one measures, the more precise the measurement is, right? You ultimately get a holistic sense of what it is, and then you actually try to actually have a better point estimate if you can actually integrate across the entire video, but it could be tedious for people. And the second thing is that is intrinsically an area where there's a lot of variability in humans because you trust the human to choose the representative beat, right? Even if they do all the tasks well, many times what we think is the representative beat might vary based on person. And that's an area of additional heterogeneity in terms of the assessment of EF. At that time, this is fantastic. We were very excited and we think this is great. We want to get to clinical deployment. We reviewed actually what it took and what the effort is to actually go from AI in the bench side to AI in the clinic. One example we actually did was that even at that time, there were about 250 algorithms cleared in kind of by the FDA. Now there's about 900. But on broad strokes, the standard and the evidence is roughly the same. By which I mean that actually most AI algorithms that you'll see advertised to you as clinicians, as well as being described to even the ones that are FDA cleared, have very few multi-center sites trials. 98% are cleared just on retrospective. meaning that the FDA will let you clear an algorithm just by saying that it worked in multiple sites with retrospective data that could potentially be cherry picked. There was no sense of randomization or no sense of blinding in any of these assessments for AI algorithms. And I like to describe this as this is certainly not the bar we use for therapeutics, right? This is certainly not the bar we use for either devices or medications. Late breakers at kind of clinical trial or at kind of any meeting is rarely, oh, we just actually show that theoretically it should work in kind of pigs or something. But that is functionally the bar that we're using for AI algorithms right now. And I think that that's where, practically speaking, there will be a discordance between what the reps or the marketing or the papers say versus what you might see in your patients. And it requires still additional scrutiny to decide kind of what algorithms you want to implement and what algorithms are useful. So with this in mind, about 2 years ago, we decided to conduct a blinded randomized trial. This was actually comparing the algorithm I described just now with sonographers for assessment of EF. And this was a late breaker at ESC kind of 2 years ago. And I want to walk through a little bit of the design and some of the results. So you guys know some of the cardiology audience, but generally the workflow in the US and not true in Asia or other places where sometimes the physician scans, but usually the sonographer scans, the sonographer does a prelim assessment, and the cardiologist edits and then creates a more. If anything, this is a great natural setting to assess AI because there's two clinical experts that are reviewing this, right? From my experience, a very good sonographer is very good. They are clinical experts. I certainly make a point to say in my essentially my presentations that these are not any less trained or less sophisticated than the cardiologist. But by nature of having two people to assess the same images, this is a great place for randomization. This is a great place for blinding, and this is a great place for active comparison. So in our trial, we had 25 sonographers. They averaged about 14 years of experience. We had 10 cardiologists. So this is the Cedars Echo Lab, and we had about 13 years of experience. And we actually randomized cardiologists in a blinded fashion to whether that prelim assessment they're seeing is actually done by the sonographer or that prelim assessment is done by AI. There's two pieces I want to highlight. One is that there is a run-in period. So we got the sonographers to annotate every single study and actually excluded the ones that they only wanted to do kind of visual approximation and didn't want to do method of this. And then we also, our primary endpoint was a non-inferiority, but also to assess how frequently from the initial to the final report was there a difference more than 5% of EF. Right? This is potentially enough to actually go from kind of two different thresholds, and we had to choose a threshold of what is a clinically or meaningful difference. There's three pieces I want to highlight that before I get to the results. The first is that we thought blinding was incredibly important. So as you can see on the right-hand side is usually what it looks like when sonographers annotate. At Stanford, the sonographers annotated on the computer. At Cedars, they annotated on the cart. In order to blind, we actually insisted all the sonographers annotate on the computer. And we also made so that the AI only showed one frame, right? That top left is what actually the model output looks like, but we didn't want the cardiologist to easily tell which one's which. So we actually made it so that we only showed one beat that was annotated by the AI, as well as that assessment of that beat. The second piece I'd like to highlight is that progress continues. From general AI, and this is true for this paper as well, is that for AI performance scale with even with the same code or the same architecture, if you actually give it more training data, it continues to improve. And we've published even further papers now, and that functionally there's rarely a clear asymptote. Always, if you can put in effort, you want to get more data. And the emphasis I would like to say is that there's a bunch of FDA cleared EF algorithms. They're actually trained on 600 to 1,000 echoes each. So it's actually a relatively low standard. We think that even our initial paper was already much better. And we believe that the model for the clinical trial, we want to give it the best chance of success. We continue to train. So it's about 150K echoes for training of the model. And you can see, I'm not sure how many echoes kind of UCLA does, but this could be about 3 to 5 years worth of echoes for any large volume echo lab, right? So this is even for a person, like individually, I'm not sure I've seen 150K echoes at this point in my career. The second piece I would say is that we also wanted to make sure it was in the exact system that clinicians use. So at Cedars, we use Dynamics. I think that's what you guys use as well. This is what it looks like when you trace on the computer. These green tracings are the tracing assisting diastole. But this is what it looks like when Brian, one of the grad students, actually inject code into and shows that the AI is, or the output. So the AI output looks like this as well. Our goal was to make it really hard for the cardiologist to know intrinsically which one's which, so that there was good blinding, and also to assess the blinding, meaning that after every study we asked, did you think this measurement was actually done by AI or sonographer? So the last piece, and I like this piece because I think that I hope that it speaks to a broader audience, is that even if you care zero about artificial intelligence, this is really a story about clinical variability, right? We intentionally chose a month worth of historical echoes that the sonographers already scanned so that we actually have a historical cardiologist report. So that if you ignore what's in orange and just look at what's in blue, you can see that this is human test-retest variability, right? This is a standard sonographer or standard cardiologist looking at the same images twice, and this is done at scale. And we wanted to do this because when we looked at the literature, the largest someone's done for doing this kind of study was about 100 patients or 100 echoes. This is actually close to 4,000 echoes. So we wanted a better point estimate what human variability naturally is. So about 3,800 echoes were evaluated. This is actually August of 2019 at Cedars. So I won't belabel the paper one, but you can see that it's a good split of inpatients, outpatients, a lot of comorbidities, since there's a lot of cardiovascular disease, a range of what the sonographer used in terms of biplane or single plane, and a range of kind of image quality. About 7% or 274, the sonographer only wanted to visually approximate. They didn't want to do method of discs. And about 3,500 were randomized 1-to-1, whether it was either an AI prelim or a sonographer prelim. I like to show this slide before the actual quantitative results because this gives you a general sense of what it actually looked like for the cardiologist. So obviously in the middle are 3 4-chamber videos. And at the trial, they either saw the left or the right, so they only saw one tracing. But I wanted you to kind of get some intuition on, actually, this is a set of tracings where on either left or right is the same image, but one is done by AI and one is done by sonographer. And see if you can tell or kind of how much effort would it take for you to assess how different they are. I swapped them so you can see.
I was going to say the more crooked lines probably than sonography.
Yes, well, no, that is actually really good. So that the fewer points, so the straighter the lines are generally human. We actually prior to the start of the study, we calculated what's the average number of lines that sonographers did. So that we try to actually match the exact same number. But you can tell there are still some lazy sonographers, right? That one does
middle left,
yeah,
right.
it looks like very blocky or something that doesn't look very great. But in general, the cardiologists are correct about a third of the time. So it was AI and they guessed AI. It was sonographer and they guessed sonographer. They were incorrect, so that they were confident it was sonographer when it was actually AI and vice versa about 1/4 of the time. And about 43% of the time, they were like, this is indistinguishable. This is probably kind of too close to tell. And one way to measure this blinding is something called the blinding index, and it was 0.88. Which is considered good blinding, right? This is something that when I get to the results, it is actually done in a blinded fashion. First, substantial change, meaning more than 5% change, happened about 17% of the time in the AI arm and 27% of the time in the sonographer arm. We initially powered the study for a non-inferiority test, but it was actually a p-value of less than 0.01 for both non-inferiority as well as superiority. The mean absolute difference was about 2.8% EF versus 3.8% EF. When we actually look at historical versus final, the changes were a little bit different as opposed to initial versus final, because there's also always inertia, or people are biased when they see a prelim, but they're biased towards being closer to the prelim. But even for comparing to the historical assessment, in the AI arm, it was a difference about 6.3%, versus in the sonographer arm, it was a difference between 7.2%. So it was still superior in the AI arm in terms of difference from historical reporting. On average, it took the sonographer about 2 minutes, so 119 seconds per study, The sonographer or the cardiologist took 54 seconds versus 64 seconds, and there was any change about 60% of the time. Yeah.
Counts for each RVU, you know.
Yeah, that's like that's like $10 or something. So there's definitely limitations in the sense that this was single center. This was done at the Cedars Echo Lab. In order to blind, the AI was weakened. We only showed one beat. There was no comparison with MRI, but generally I'm not a fan of doing cross-modal comparison for this kind of study. And really further work is needed to assess the long-term impact. But this is external validation of an AI model with publicly available code and representative treating data. So the 150K echoes were actually all from Stanford. So this is a completely geographically distinct echo study. I would say that we didn't directly test, but I imagine there's really no patient overlap. There was randomization with an active comparator. Many trials of AI generally were saying, oh, what's AI with assistance or without assistance? But you can imagine that drastically changes kind of how you feel. The blinding was successful. I would say that I don't think there's bias towards either the clinicians liking AI or not liking AI because they really can't tell. And ultimately, this is the largest test of clinician test-retest, right? So even if you don't care about AI, generally humans vary about 6 to 7% in terms of how much they vary when they assess EF.
David, was the blinding, did that include for the clinicians, the clinical history of the patient?
Yeah.
Prior echoes that the patient had?
So they saw no prior echoes. There's no clinical history. It is as if you only had the PAC system and nothing else. Yeah. So I think the more I think I would say detailed among the readers or the echocardiographers will look through everything. We treat it as like, if you only had just the images and nothing else.
But the sonographers presumably.
Similarly, can't see anything.
Okay.
So we intentionally did not show them the historical, and they don't have kind of prior echoes or anything like that. Yeah.
And I don't know if I missed this on the last slide, but was the AI initial read closer to the historical and changed further after physicians corrected it?
Yeah, I would say that's actually not part of the paper, but so I mentioned this was 6.3% versus sonographers 7% after the cardiologist changed it.
Yeah.
The AI was actually closer than either the AI or sonographer or the after cardiologist changed. So like the AI to historical was about like 5% or so.
Right. Yeah.
So it just shows that there is a lot of clinical and variability.
Yeah.
Yeah.
This study, were there factors that you can identify in which echoes were more likely to need a significant change in the EF? So are there like pristine looking echoes that the cardiologist needs to change? And then, or is it like what I would call, I don't know, the computer doesn't call for image quality, I call for image quality. But does like image quality affect the machine as much as it affects the cardiologist? Or are there other factors that, seem to be at play in terms of what gets changed?
Yeah, that's a really great question. And I think the readers had that as well. I don't have it in this presentation, but it is in the paper that we did subgroup analyses on image quality, inpatient, outpatient, kind of biplane, single plane. All those things trended towards AI. So there wasn't a very clear certain group that was better or worse. The difference, I think, kind of, I would say in an exploratory way, the difference between AI sonographer was least when it's poor image quality. So like actually for the better images, the AI was more precise, or the cardiologists liked that better. But for the more worse images, that was one where I think the confidence got closer to zero.
This isn't like a tool that you would say, well, I'm going to read all the really good echoes and take all the credit, and then when they're crummy echoes, let me give it to the AI. That wouldn't work. That's not a model that would work. Again, I mean, I guess the question is if it would do as well as as a cardiologist, then it does. I mean, how much value does it add in the technically? It adds less value in the technically difficult.
It always adds value. So all of them were trended towards AI was better, but I think the confidence is to be less kind of strong confidence.
And then one other question: what platform was it tested on, or was it generated on, and what platform does Cedars use?
So what the cardiologists and sonographers see is single dynamics, and our ultrasounds are vast majority epics. There's a kind of a little bit, kind of a range of kind of, I would say carts, but I think the Epics are 90+% of the carts we use.
And also at Stanford, that was the same.
That was also the same. So, or Stanford uses Philips, but also vast majority of carts are Philips.
Thank you. Appreciate it.
Yeah, so the transducer / ultrasound carts are actually very similar. So that probably helped in terms of external validation. But we've had other work where even using point of care ultrasound and stuff like that, this model still works quite well. So I'm less clear, but this doesn't describe it, whether there is actually loss like transducers are originating. Yeah. So, and the last thing I was going to add is that kind of this has been spun off as a startup. So actually, after the trial, we actually submitted this and other data to the FDA, and this is FDA cleared. So we're actually not paying, we're not charging a lot of money or any money for this. But if you guys want to implement it in your system, or if there's anything just kind of running the Echo Lab, we are still looking for large academic centers to run it. Actually, this morning, I was talking with the Cedars Echo Lab, but really talking with a lot of it is like working with IT on how to integrate these things. But ultimately, we think it's a win-win.
Maybe not so much we'd love to. It's our lawyers have a different problem.
Yeah,
Well, the legal.
absolutely.
That's kept us, yeah. That's a problem. I kind of wonder from a public policy, I don't think how your work will ultimately change how healthcare systems view these data sets.
Yeah.
For the greater good is to frankly have more consistent quality.
Yeah.
I have a feeling, unfortunately, it's going to be more at the level of healthcare admin and frankly lobbying at a higher level. I'd love to hear your comments on that after your talk. So
Yeah, no, this is a good time, and I think it's absolutely true. Where healthcare systems generally see that there's friction because a lot of times IT don't know how to integrate these things. You actually need a vendor or someone to help you do this. Broadly speaking, in my mind, I think of this as maybe the early steps, because this is cleared AI that is not meant to be fully automated, right? This is a prelim. So in fact, our FDA clearance this is for assistance of cardiologists and sonographers. Theoretically, at least personally, I think it's low risk because I'm not telling people this is actually the final, but this can potentially help you in the Echo Lab where you do have kind of clinicians actually give the final sign off. The piece that, Eric, maybe this is not what you're describing, but is actually super important is that actually the reimbursement model for a lot of these is actually very hard, right? In the sense that there's not a CPT code to do this, even though there's CPT code for strain and other things like that. So like most of the time, hospital admin is like, well, why would we pay for this? Because this is just additional effort. You cardiologists are just lazy. You guys should just do all this work and do all the tracings. Yeah. All right. So I have one more vignette, but this is a good pause point. But the second one, and I'm happy to answer more questions after, is actually this is a vignette of an 82-year-old gentleman. He has HFpEF, or he was diagnosed with HFpEF. He has AFib, he has sick sinus syndrome, and he actually have left carpal tunnel syndrome. And actually in 2019 at Cedars, he underwent an extensive workup for dyspnea on exertion and shortness of breath. So I think that with a lot of more popular interest, this is actually something, it's clearly, I'm hinting at amyloid, so you don't have to really focus on it now, but this gentleman did not get a diagnosis. Well, you'll notice that actually, even for the criteria that we traditionally think about, he didn't meet criteria, right? Like low voltage, not quite, right? It might be in hindsight, it looks a little bit small, but definitely doesn't meet low voltage criteria, either on limb or kind of precordial leads. The wall thickness, I would say, is standard sonographer wall thickness, right? Like kind of in the sense that like, the interventional septum is measured at 1.32. But, in hindsight, now that you have the diagnosis or you have a very leading stem, maybe I might have made it a little bit thicker, right? Maybe this is actually someone that's closer to 1.5 or a little bit more. And the emphasis, and actually, I was like, you guys know the people here. I should probably walk up the name, but you can see he actually got multiple echoes, and multiple of them actually, or none of them said consider amyloid, and none of them actually got to the point where someone actually received this diagnosis, right? And this is not to pick on anyone, but I would say this is clinical practice. We're busy. We sometimes have the time to look at the chart. We sometimes don't, but a lot of it is fundamentally there's a lot of information that's already rich in there. But just not being utilized. So What I like to say is that kind of the literature suggests that for a diagnosis of amyloid, patients are currently seeing about 4 specialists and taking about 2 to 3 years to initial diagnosis. And this is despite, Helios-B came out and there's a variety of kind of great studies on tafamidis, but ultimately these drugs both have improvement of quality of life as well as a mortality benefit. And in Helios-B, the subset that was diagnosed earlier or had earlier disease had actually better impact in terms of treatment. So it's important, and ultimately, precision medicine needs precision diagnosis, right? Even if you can actually have great therapeutics, if you don't get the patients to the great therapeutics, it doesn't mean as much. So about 2 years ago, or I guess, close to 2 years ago, we published another paper, which is actually a AI precision assessment of left ventricular hypertrophy, where we actually both assess hypertrophy, hopefully in a more precise way, and as well as distinguish between the reason why there is LVH. So one example I like to give is similar to the other description, is that you can be more precise when you actually measure every single frame and every single beat and come up with a consensus measurement of wall thickness. I like to show the video on the right-hand side is that actually we are very intentional. You can see that there's a pericardial effusion. A lot of the less well-trained models would definitely get confused by this, right? Something that we think that we developed a really good model that with the pericardial effusion, it will not use that or choose that as the kind of the posterior wall. We show that actually when we use this AI, which we call economic image, that the variability from study to study is actually much less. So like same patient, multiple studies, what was the measured wall thickness? You can see kind of compared to kind of X and Y versus the human reported measurement. You can see actually there's much more variability when you actually look at X and Y, right? Oftentimes we ask the sonographer to look at the historical report. I'm not sure that they always do it. And sometimes we do have very disparate measurements of wall thickness or any other thing across study to study. And in this setting, we also, after identifying hypertrophy.
Sorry, do you mind going back?
Yep.
What's the reference measurement?
The
Cardiac MRI, I'm sorry.
The reference measurement is actually, so this is on the right-hand side is actually just 2 different studies. So like it is whatever's the later study is actually the reference in the earlier study.
Okay.
So this is less about cross-modal, but highlighting the variability across studies. So like if you actually got AI and humans, what did they measure as that particular measurement, but in 2 different time points of the same patient? Okay. It's a great question on the side, but maybe I'll answer that at the end. Hopefully people can hear me. I saw it. Please unmute. Yeah, maybe they did in the last 30 minutes or 40 minutes or so. Okay. The last thing I was going to say is that kind of obviously we know there's many reasons why there's hypertrophy. Even if you get that, that's not the same. We know that historically there's things like the night pattern, many other things that there is intuition about prior to kind of resonance imaging. But we do think that AI can pick up much of that signal as well. So the algorithm actually can distinguish between, say, aortic stenosis, HCM, ESRD, hypertension, amyloid, and such. And the one piece that I like to highlight is that this is a model, because it's using case and control that all have hypertrophy, it's not being shortcut on the hypertrophy. There are other models that have been trained, you can inject amyloid, but it's actually using controls that don't have thick hearts, right? Because then you're actually shortcutting on the fact that there's a thick heart that's a much more obvious phenotype. And then you actually, show them hypertension or AS, that would also flag it as being very high for amyloid, even though that's actually not the case. We were very intentional about this in the algorithm.
For the testing and validation of these cohorts, like for the amyloid cohort, they were diagnosed by PYP, and for the hypertrophic by genetic testing, or? Yeah,
so we actually used the clinic cohorts both at Stanford and Cedars. So that kind of, there's a wide range, so that for the amyloid, it's some people have MRI, some people have biopsy, some people have PYPs. And so the HCM, many of them have genetic I would say kind of either pathological variants or VUSs, but similar as you know, for HCM, not everyone has a genetic diagnosis or there's not a clear genetic marker, but these are patients that I would say the experts thought was HCM or was amyloid. Yeah. Okay. I like to highlight that this is where I see a lot of potential in AI, because this is where there's clearly underdiagnosis. One example is that kind of, if you look for the TTR diagnosis incidence in the US, it's about now 10K, and as opposed to 7K. But if you simply looked at the incidence of aortic stenosis and multiplied it by the rate of in aortic stenosis, you would imagine that the US has about 20K cases. And if you actually look at the incidence of heart failure with LVH and then multiply it by what in the literature suggests is the rate of amyloid in heart failure with LVH, I mean, this might be an overestimate, but it would guess 220 cases or 220K cases a year. Ultimately, and I didn't realize this, but 1 in 5 Medicare beneficiaries get an echo every single year, right? Kind of, I think echo is a fantastic place to do ML because it's the top of the funnel. Most of the patients, whether they're coming in for kind of AFib or for heart failure or just shortness of breath, will get an echo. So this is a really great screening tool to really capture people at the beginning of the funnel rather than towards the end when they've seen many people.
A real kind of related question. How do you feel about the ECG algorithms that have been developed for some of these similar conditions and kind of starting at the top of the funnel?
Yeah, it's a great question. The Achilles heel, and I have not seen, or there's great work, but the Achilles heel for screening tools is what is the positive predictive value, right? You want to be at some frontier where you're not kind of like sending on 10 Zio patches and get one positive. I think that very few prospective trials, but the Mayo Group did do a prospective trial there. And you'll see that even that, I think the PPV was, I think around 30% or so, which is actually really good. Implicitly, we know that amyloid being rare will actually have a much lower PPV. So that's why it's always complementary, but there are both kind of pros and cons for different screening approaches. The echo, I would say that this algorithm theoretically should have a much higher PPV because these are not true asymptomatic people. They get an echo for some reason. There is enough friction to getting an echo that one actually needs to have some kind of symptom. Yeah, so this is the part where I'm really excited, where we've actually started another clinical trial, which is the idea is that we will actually review many, if not all of the historical echoes done at Cedars and call up the patients that are ranked really high by the algorithm, but do not have a formal diagnosis of amyloid. So this is something where we were actually funded by the Moore Foundation as well as kind of Kaiser Permanente to do this at 4 sites. The overarching idea is that for each of the sites, we'll grab about 3 years worth of echoes and then just filter for the top 100 or so kind of people that have been chart reviewed to not actually have a formal diagnosis, but is suspicious enough that will be seen by the amyloid clinic. Ultimately, the amyloid clinic will do what they need to rule in or rule out, but obviously can almost defer to them to the standard of care. And we want to see how many people actually get a new diagnosis and how many people go on therapy. And what I like to highlight, this is the retrospective data. So this is even before calling patients, but this is actually all the echoes at Cedars from 2019 to 2021. On the top right is actually the histogram of model predictions. So you can see that the vast majority of echoes are very low probability, 0. A very long tail where histo probability close to 1. And then if you actually then stretch that out to based on actual at each kind of percentile, what the proportion is already with known amyloid, that's in dark green on the bottom right. So these are patients that if are already seen in essentially our heart failure clinic or already seen in kind of our transplant clinic that have a diagnosis. So obviously we don't need to see them as part of the clinical trial. But we're really focusing on that kind of top middle, which is kind of the light green, which is high risk, but no confirmed diagnosis. And I think that that's the piece that we're really excited about. And actually, that's actually the story of the gentleman in the first vignette. So he actually was diagnosed with TTR amyloid after our clinical trial. He was started on the Alnylam drug, and it was someone who actually had many echoes and actually was flagged but not recognized in the clinical setting. So these are the 2 big vignettes. I think I'll go through a couple of short things just to highlight where I think these are going, but broadly speaking, kind of there's the opportunity to build AI algorithms in echo at a larger scale. We are also doing a similar screening approach for MR since we have a lot of proceduralists that want to do procedures. So this is Ame. He was one of the startup fellows actually 2 years ago, and he actually led this work. We have a screening tool for mitral regurgitation. He also did work on tricuspid regurgitation. It generally also worked really well at Cedars and Stanford, and we think that this is a good automated approach, but recognizing that, in general, clinicians are very good at assessing MR already. And the last piece I was going to say, and I think this is kind of reiterating some things, which is that ultimately, for AI, it's both you need kind of technical sophistication, but it's really a lot of effort to organize the data. So I would say that kind of we actually published a recent paper, which we call Echo Clip, which is a foundation model for Echo, which we continue to expand how many echoes we can analyze with AI. This is close to 1 million or more than 1 million echoes. And this actually builds a lot of the foundation models that people are really excited about. And this is the demo, and I leave it here because it's a little bit provocative, but we're at a paradigm where now you can like upload a series of kind of 50 to 100 images. This one only has 26 to shorten the processing time. But this is what Echo Clip can do. It can look at all the different images and videos in a study and actually come up with a prelim report. So not just measurements and not just kind of general assessments of EF, but actually can create a whole prelim report that can be helpful for sonography and radiology. And this is actually sped up, so it actually takes some time to process, but then it creates a report. So, I'll probably pause here, but yes. Okay. I'm going to pause here, but would love to answer any questions and see if there's anything that you guys wanted to discuss. Yeah, we can do the question too. If that's
Sorry, I joined a little late. I'm just one of the second years.
Great.
Does the model take the 2D images, or does it take the raw data from the ultrasound and interpret them directly?
Yeah, so in general, most echo labs don't store the raw data, right? So even the DICOMs that are stored are tremendously compressed. So generally, we are using the DICOMs, and those a study ranges from like 500 gigabytes to 1 terabyte. The raw information would be every single study would be about like 20 terabytes or so, or 20. I think it's 20 terabytes. So it's like or 20 gigabytes, but it's just too large to store. So we're mostly on the DICOMs.
Well, one of the things that I think, and this is so great, and you're picking good diseases because they're prevalent, but not that prevalent, where you are going to make diagnoses in so many patients that you may not have the ability to then schedule, refer, treat, right? Because if you look at something like hypertension or athero, you never have the resources from an EKG to be able to take care of so many patients. It becomes kind of a logistically, how do you deal with all the data that you're going to get? But these are great diseases because they're prevalent, but they're not so prevalent that you're going to sort of sink the ship with all the data. I'm sure you guys are working on the back end about what do you do when you get the diagnoses? How do you follow up with patients? Make sure people have echoes for random reasons. They come in for a headache and they get an echo. Right?
Yeah.
So you make a diagnosis that's unexpected, and then you have to find the patient and then initiate a treatment, and maybe in somebody who's totally asymptomatic that may not have ever maybe needed treatment yet, but you're going to change the algorithm for treatment, I think, with these technologies. So I'm just curious how you guys have thought about that.
Yeah, I would say that diagnostics are not useful unless it's paired with a therapeutic, right? That's why we were very thoughtful in using talking about amyloid first, because if anything, there are many amyloid clinics opening up, right? There's new therapeutics, many heart failure specialists who are starting in interest and can't fill their clinics. So
that's why it's a great topic. I'm saying when you start to expand the technology, though, I just worry start really looking at MR twice the volume as AS. There's so much complexity in terms of etiology and symptoms. So much goes into it that you really need to build the system to deal with the data.
Yeah, I would say that, for prospective or deployment, the algorithm is not the hard part. The hard part is getting alignment from the clinician that wants to treat them, right? So our interventionists are hungry, so they want to see more MR. Similarly, if you guys want to see more amyloid or MR, we'd love to deploy at UCLA, but it really is like, do you have the right alignment of interests, right? So like, Eric, if you want to see more cardio-oncology patients, we can try to funnel them all to you.
Absolutely.
You have the right insight.
No, UCLA is interested in more MR and TR, no question.
Yeah.
But I'm just talking about as a system in general, when this rolls out, I'm thinking more broadly, just
Yeah.
in terms of this technology obviously being so experienced in it, how you see it applied to different therapeutics and how you.
Yeah,
Because I know the field talks about that.
Yeah.
Like,
it's a fair question, and in terms of like, I don't think I have a really satisfying answer for you. But the main thing is that these are actually patients that already have it and we're missing, right? These are certainly not patients that are asymptomatic because, like you said, they got the echo. One of those because of the headache, they are walking around and saying that we think they have they're kind of different treatment. The societal cost or stuff is actually a much broader issue, right?
Yeah.
And so many drugs are super expensive, but that's I think beyond kind of what I can do anything about.
None of your echoes were from executive health.
Yes.
Those are the ones that don't have any diagnosis relevant. So,
They're fun to read.
and then was there any any human evaluation of those echoes from the time the machine said this is a high risk patient to the time somebody picked up the phone and called the patient? Was there any requirement for cardiologist or a clinician to look at the patient's record and say, oh, wait, hold on, this is maybe not appropriate to call this patient, or this is strongly suspected, or was it automatic from the machine to the phone call?
In our clinical trial, we had the downstream clinician chart review first, right? So it was our amyloid specialist who then looked, is like, I'd be happy to see this patient in clinic, or actually this patient already had a formal diagnosis of HCM. I also don't want to see that. So I think that we are trying to be picky on who we see since we can't see very much. But it is not a pure reflex to then get scheduled for clinic.
Working on any like multimodality stuff, like things that you could only see on cardiac MRI, linking that with a paired echo to see the diagnosis of viable myocardium or something like that on echo.
Yeah, we've definitely, we're very interested in that. We have some work on kind of like, can you detect scar from echo? Unfortunately, we could not. But we also have some work linking EKGs, echoes, chest X-rays, angiograms, and CTs. The one thing I was going to say is that if anything, the one piece of advice is that for AI, the scale of data is actually so important that actually drives a lot of how I choose products. Meaning that, obviously I'm interested in MRI and CT as well as an imager, but generally that's less tractable if you only have 100 or 1,000. You do not, even if you have a messier data set and or worse labels, if you can get to 100,000, invariably the models get better. So the trade-off is such that I tend to choose projects primarily in echo and EKG, but we do have some projects in every modality.
David, yeah, and again, I'm so sorry for coming late, and thank you for sitting down and talking about this. You introduced my segue into my bias question to you. I think on a clinical level within cardiotoxicity detection, I would make the argument that's one of the biggest sort of opportunities to explore on a wide scale, because you'd already say the cancer population probably has the largest imaging data sets to move from. And on top of that, you have the most dynamic potential for detection of subclinical changes, because these are echoes done within a relatively short period of time for screening.
Yeah.
Right. However, more often than not, and I have an anecdote to show that just happened this week, it's more unfortunately wrong diagnosis or inappropriate inadequate EF assessment.
Yep.
And that's driven by a lot of factors, right? Inter-observer variability, not using best practices, frankly, poor strain measurements, right? So, I think the problem is, within our field is that it's still the definition of what we define it is very messy, but also a lot of it is from, as you point out, suboptimal, data that we have. But at the same time, there's so much potential that if we could make it systematically more consistent, then the biggest benefit would be, frankly, as much as I'd love to see these patients, we could, stop interruptions and isolating electronic therapy. But we see a lot of issues where these EFs that come back are not good, and we have to follow up. I would think that we would benefit from a more systematic scale. The deep learning data, I think, in the cardio-oncology realm, to me, at least from my understanding, is still very nascent. There are some people looking at ECG models and AI, but I think that's still a very difficult. I'm just curious to know where you think the directions are and the major challenges to overcome.
Yeah. So I'll give you two opinions. One is a little bit less conventional, one is more conventional. But broadly speaking, I completely agree with all of this, right? I do think that this is a more precise EF, and I wish that this could be used in a cardio-oncology setting. Too often, right, like in the interest of not discontinuing, even when we think it looks a little bit worse, we might still call it 50% and like keep going or stuff like that. So like that's an area that is a challenge where if you had a more precise measurement, that is a little bit better. I'm actually of the camp that I don't like strain. And the reason I give that is that
Stanford, you were at Stanford?
you know, we
No, I agree with you. And that's the other thing, that's another issue. Strain's not been shown to be clinically impactful, right? So
it's not even strain. Only strain has a paper that's like intra-vendor comparison. No other clinical measurement do we actually depend on the vendor, right? It is not a measurement if you actually doesn't make sense from vendor A to vendor B, right? There's no like GEF and there's no like Philips EF, but there's like a GE strain and a Philips strain. Like that to me speaks to that the technology is not quite there. Right? And I think that that's where you know, we can automate strain and stuff like that, but I generally don't like it as much as a way to kind of make clinical decisions.
I mean, just quick personal anecdote, like, I got called about a woman who was treated here for HER2 breast cancer. Yes, here at UC Irvine, all normal, like during her septum. She's actually an intern in a medicine residency in rural Virginia. Then the first echo she gets over there, EF is dropped to 55%, strain is -12. So fortunately, she's a doctor, so I can call her and just tell her, this is what you need to do. Just tell your cardiologist, they stopped chemo and everything, put her on the soprolol or Revitol. I said, just tell them to repeat it with Definity.
Yeah.
And they did it, guess what? It's normal.
Keep going.
You know, but if you, but that's because you have these medical connections, but like, I'm sure this happens a lot in the community where breast cancer care is done.
Yeah.
And I do think there should be a system in place to have more consistent, you know, these kinds of measures, but I just don't know kind of where we're at in that space.
Yeah.
So, yeah, so these are just kind of the things that can be very impactful. I think using your kind of work, just, you know, excited to get there at some point. So thank you for,
Thank you. Yeah, it's really great to be here and definitely want to kind of build connections and if there's anything you guys want or kind of collaborate or try to deploy at UCLA, I'm super excited for all those things.
Thank you.
I'm here for 30 minutes. Yeah.